Hi, I'm Dr. Suchitra. In this session, I'm going to talk to you about vasculitis or vasculitis as it can be called, but we'll just call it vasculitis. Basically, there is inflammation in the blood vessel wall. There was a Chapel Hill consensus in 2012 which divided the vasculitis into three types based on the size of the blood vessels involved: large, medium or small. This picture, if you remember this and understand this, that will be very useful for you to understand vasculitis because it shows the Chapel Hill consensus, what was arrived at there. So basically, large vessel vasculitis is Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis is polyarteritis nodosa and Kawasaki disease. And in small vessel vasculitis, you get ANCA-associated small vessel vasculitis, which can be microscopic polyangiitis, granulomatosis with polyangiitis, or eosinophilic granulomatosis with polyangiitis. Under immune complex small vessel vasculitis, you get cryoglomulinic vasculitis or IgA vasculitis, which was called Henoch-Schönlein purpura, and hypocomplementeremic urticarial vasculitis, an anti-GBM disease. I'll talk about each one briefly. We'll start off with Takayasu's arteritis. This is quite common in our country as compared to the other large vessel vasculitis, which is giant cell arteritis. So these two are the large vessel vasculitis. In India, Takayasu arteritis is more common. In giant cell arteritis is more common in Caucasian population. They think there might be a link to Mycobacterium tuberculosis. This investigation has been ongoing for a while. There has been no definite proof, but there have been suggestions that it may be linked to the heat shock protein. The clinical features of Takayasu's arteritis depends on which vessels are involved. So it can lead to claudication of the upper extremities, or if it can lead to dizziness, syncope and headache if the vertebral and carotid arteries are involved. If the renal arteries are involved, it can lead to hypertension, and in some patients they can have constitutional symptoms. This is an angiogram showing the normal aorta and the blood vessels from it, and this one shows arteritis. As you can see, it's swollen and aneurysmal. This is one classification that may be used depending on angiography and which parts of the large vessels are involved. Whether it involves the aortic arch, it starts off with 1 if it's just the arch, and depending on ascending aorta, descending aorta, and if the whole of the aorta is involved, it's 5. This shows the renal artery involvement, as you can see by the arrows, and there is some stenosis in this part of the aorta as well. There is an Indian Takayasu arteritis score with acute phase reactants, which helps you decide if the disease is active or not, because it's difficult to biopsy and find out whether this disease is active or not. So you have to use scores like this, which are helpful, and you can't do angiograms all the time. Going on to giant cell arteritis, as I've mentioned before, it's mainly in Caucasians, and it can be cranial or non-cranial. It used to be called temporal arteritis because they thought it was only the temporal arteries that were involved, but now there is a non-cranial large vessel arteritis. So they call it cranial and non-cranial and giant cell arteritis rather than temporal arteritis. But cranial arteritis is temporal arteritis symptoms, which are jaw claudication. That is when they chew. After a while they get pain, not at once. They can get headache and visual symptoms, which are the major problem because of ischemia. And you have to start steroids at once without waiting for a temporal artery biopsy. This is an important point which can be asked in exams as well. That is, you should not wait for a biopsy. The patient can lose sight, so they can lose their vision. So you have to start steroids at once, and you have to biopsy within a week or 2. It doesn't make that much of a difference if you biopsy it within a week or 2. And usually it's only one temporal artery that's biopsied. And there is association with polymyalgia rheumatica. It's in the same age group and there is an association. Shoulder and pelvic girdle muscle pain is mainly polymyalgia rheumatica. The inflammation in this case causes intimal hyperplasia and luminal narrowing. Because of the narrowing, it's the ischemia that causes the problems. And you can see macrophages forming giant cells, but these giant cells are not essential for the diagnosis in a biopsy. So you don't have to see the giant cells in giant cell arteritis. The other features may be enough to make a diagnosis. You can see neogenesis, that is normally only the adventitia, that is the outermost part of the blood vessel, has blood supply, vasorum. But in this condition, there is neoangiogenesis, which is abnormal. So the intima and media, which is the middle layer and the inner layer, which are normally avascular, start developing new blood vessels as part of the inflammatory process.